Good evening and welcome. It's a pleasure to welcome you on this lovely summery evening to our exciting series of conversations with some of the most inspiring women at Imperial College London. I'd like to thank Pinky Lalani and Marty Wickstrom for their support in helping to create this series and for connecting us to their wonderful network of friends. Welcome to all of you, and welcome back to many of you who've been joining us before. Imperial College London is indeed one of the world's greatest universities, focusing on science, engineering, medicine, and business. We have some 20,000 students and 8,000 staff pursuing the forefronts of their fields. We also have some of the greatest women academics in the world. I'm excited to say that our research discoveries are ever more present in the news and in our teaching. And every day we learn things from the youngest members of our community. Thus, in this series, we decided to connect some of our breathtaking career moments with the ideas and aspirations of our younger colleagues and students. And tonight, we begin with a very interesting conversation, improving treatment for patients, why statisticians count. This will be a look into statistics and its applications to medicine. So let me begin by introducing our luminaries. Professor Deborah Ashby, OBE, is the director of our School of Public Health. She also holds a chair in medical statistics and clinical trials and was the founding co-director of Imperial Clinical Trials Unit. She is a chartered statistician, and her research interests are in clinical trials, risk-benefit decision-making for medicines, and the utility of Bayesian approaches in these areas. Deborah is the immediate past president of the Royal Statistical Society. She has sat on the UK Commission on Human Medicines and acted as advisor to the European Medicines Agency. Deborah was awarded an OBE for her services to medicine in 2009. Rachel Phillips was awarded an NIHR Doctoral Research Fellowship in 2018 to undertake her PhD at Imperial. Her research focuses on the reporting and analysis of adverse effects in drug trials, and she is developing statistical methods to better identify adverse drug reactions. Alongside this, Rachel works as a clinical trial statistician across a broad range of disease areas at the Imperial Clinical Trials Unit, and she's a member of both the trials methodology team and the clinical trial statistics group within the unit. So this will be a conversation, and we will see how these impressive women have come to be the statisticians they are today and where they are heading. We welcome your questions. Please put your questions in the Q&A function, and our team will pull them together for our discussion. So let's start. Deborah, you've had many discoveries and many aha moments throughout your career. You've also been at the center of activity during the pandemic. Can you tell us about your discoveries and your recent aha or perhaps oh my moment regarding this dreadful coronavirus?
Thank you, Alice. So as a statistician, we don't necessarily have the big aha moments that many discovery scientists have. On the whole, we're careful people, we design and analyze studies, and then also thinking carefully about what are the methods we could use to do things better. And that's almost for me the sort of the playing around, the intellectual sort of fun, if you like. But over the years, I have worked a lot on clinical trials, which are experiments to find out what works best for patients. And you often compare two groups, maybe more groups. And if you like, the fun I had was doing what's called Bayesian statistics, which is a particular way of thinking about the world. And I wrote some early papers on actually applying these to what's called data monitoring, which is seeing whether there's enough evidence accruing from the trial to see whether it should stop. And they were fairly simple examples. About a year ago in the pandemic, all of this suddenly came to fruition because one of the things we do as statisticians sometimes get involved in what are called data monitoring committees, which is we get to see the accruing data in confidence to make that call. And I was asked towards the end of March to chair a data monitoring committee for a COVID treatment trial for people in the community. and they are using the most amazing Bayesian statistics. And so, to cut a long story short, just about every week for the past year or more, I get data from these trials looking at the new treatments. Some of them we've had to stop because they're not working. One of them, budesonide, an asthma treatment, actually works really well. And those really are the aha moments. And it's the combination of it making a difference to patients' lives, but being based on the kind of statistics I've been working on for a couple of decades. And that is just so satisfying.
That must be very exciting to find something working, be able to push it forward, or to find something not working and say, oh my gosh, you have to stop. These are very interesting jobs. When you think about statistics, you don't think about someone doing that.
No, absolutely. And they're also a big responsibility, because the tension you're having if you see that it looks like a treatment is working or it looks like it's not going to be good. If you call it too early, nobody believes it. If you wait too long, then the chance, you think, are we putting patients at risk, or are we not making a treatment available when it should be available? So that's where the careful balance comes. And I don't do this on my own. I have a committee of clinicians and other statisticians and trialists to help me do it. But no, it's absolutely not what I thought I would do. I mean, I'm a mathematician by original training. And if you'd said to me, you're going to be making calls on national, international clinical trials, I thought, well, how on earth do I get from there to here? But no, it is enormous fun. And having the confidence of them, the methods and the training I've had actually means that you step up when you need to.
Absolutely. Thank you. And Rachel, you're in the midst of your PhD and actually thrust into the pandemic as well. Tell us, what were you pursuing as your thesis, and how have you been involved in the pandemic?
Thank you, Alice, and thank you for inviting me to be part of this great series. So I'll start with saying a little bit about my PhD. So I think over the last 12 months, COVID has meant that we've all become fairly familiar with clinical trials. And the types of trials that we've mainly been hearing about are these later phase 2 or 3 drug trials. And these are trials that are typically designed around questions of identifying benefit. So if we think about COVID-19, we're looking at outcomes such as preventing the need for ventilation, for example, or reducing the length of hospital stay, or reducing the number of deaths. But we might also have some other secondary outcomes relating to the side effects, or the harmful effects of the interventions or the drugs we give in. But in truth, we don't really know what these effects will be in advance. So current practice is to collect everything. So this will include events that are related to the disease, for example, the population that are taking part in the trial, and some of these will actually be related to the intervention. And it's these related events that I've been trying to find methods, so statistical methods that we might use to better identify these events from all of that background noise of the events that are actually just due to disease or the population of interest. And I've been working on this for 2 years. Yeah, it would have been 2 years back at the start of the pandemic. And then around April or May time of last year, I was actually asked to take on the role of a trial statistician on a COVID-19 trial that was being run by an Imperial team. Now, this had been rapidly designed with the involvement of my supervisor, Dr. Victoria Cornelius, and statistical colleagues in Newcastle. And they needed a trial statistician who would be responsible for running the analysis for this trial, producing the interim reports that go to the committees that Deborah's mentioned, and really just being involved in the day-to-day running of the trial. And it was an opportunity I felt I couldn't turn down. It was a chance to get involved and make a difference, hopefully, in something that was having such a profound impact on all of us. But it did mean that my PhD had to go on hold. So rather than submitting at the end of last year, so in December, which was the original plan, I'm actually now currently approaching submission. So hopefully to get that in the next couple of weeks or so.
Well, we wish you all the best for that. I don't know if you can tell us whether the trial was successful. Was it one of the therapies that is being used?
It's actually still ongoing at the moment. So we are, we're exploring international sites at the moment.
That's very exciting and very interesting. And you must, it's been, a worthwhile detour, and we thank you for your work. For everyone's good. Both of you mentioned working teams. Rachel, you're on a trial team and you're the statistician, and Deborah, you mentioned the team that you're working with. I wonder if you might say something about the collaboration, and are you usually the lone statistician working with a bunch of other people, and how do you work across disciplines and find common language?
Gosh, no, absolutely, we're not the lone statisticians. I mean, there are statisticians who will sit in their office quietly doing theory, but certainly people like me who work in applied areas don't work like that. So one of the skills I've had to learn is how to communicate statistical ideas, how to listen and ask about ideas I don't have. So typically we'll be working with clinicians, with scientists, with trial managers, with patients and public, involved in design of trials and helping us run them. And just about everything I do has that sort of mixture of people. And then you're not alone as a statistician either. So on the committee I chaired, I've got one other statistician on that. But then we are working with the equivalents of Rachel who are doing the analysis. In this case, it happens to be an organization called Berry Consultants in the States. So we always have to time our calls so that they're getting up at 7 or 8 o'clock in the morning and we're kind of somewhere mid-afternoon. And then there's the statisticians, in this case in Oxford, with the trial statisticians. So we all talk, we check things, we query each other, and it's real teamwork, even though I haven't met some of these people except virtually. We really have bonded. So it's a skill that, I mean, I think it's important in all areas of science, but certainly as a statistician, it's often described as we get to play in everyone else's backyard. But, if you don't like the people who find other people's backyards, you're kind of in the wrong job. But, it's one of the things that sort of keeps life really fun. And you take stuff that you've learned with one team and then you say to another team, well, we could perhaps do it a bit like that. So I think it's one of the things as statisticians we do, because we tend to work in different teams on different projects, is that we help we help ideas transplant quite quickly.
Yes, you must learn quite a bit of different science along the way and different approaches, and a lot about the diseases and the medicines you're working with. You
actually learn the skill of getting up to speed quite quickly, because if someone comes with a new problem, or when I was doing drug regulation, you never knew what was going to come in that month. You rapidly learn where to get a potted version and then how to interrogate it to find out what you need to know. But my clinical colleagues are brilliant. I have learned so much from them at Imperial and the places I've worked at before that. So it makes life really fun.
Well, the pandemic seems to have brought out the best of that in everyone, bringing their knowledge and experience to the front, and then immediately figuring out a very coherent pathway forward. And
absolutely,
Rachel, you must have seen this when you dove into that clinical trial that you're working on, and you see all of these collaborations.
Yeah, it's been great to see, and I think just how open and flexible everyone has been. We've had trial management meetings where you've got doctors still on the wards, connecting on their phones, and you've got statisticians from across the country that have signed up to be on our monitoring committees, like Deborah's been saying. So yeah, it's been a real bringing together of lots of different people.
I wonder, your work sounds so exciting and so varied, and yet the word statistics and statistician to most people might mean something very different in their minds. And I think a number of our audience might be wondering how you decided to become a statistician, or whether you really love maths and how you discovered statistics. And I wondered if you could share your journeys to where you are now in the middle of these heated challenges with us. But what's the maths and statistics route?
Yeah, well, I didn't start out thinking I wanted to be a statistician. I was at a girls' grammar school, which I think in the 1970s was actually the widening participation of its day. I mean, I didn't come from a family that had gone to university. When school said I was fit for university, I said to my parents, "What's a university?" But my parents were both numerate, and I really enjoyed maths. So by the time I was sort of coming up towards sort of 15, 16, that was the thing that really sort of I enjoyed doing most. So it was an obvious thing to go and do at university, which I did. And somewhere, probably towards my halfway through, we had some statistics courses, and I just really enjoyed that, partly because I was just a bit better at it than some of the other things I was doing, but partly because I could suddenly, having not been terribly interested in applications, I guess I was getting a little bit older, more mature, and suddenly I thought, oh, I can really see that it makes a difference. And that I think because it was a newish subject then, that I could actually understand some of the relatively cutting edge things. So I decided to go and do a master's in medical statistics, and I had no intention of doing a PhD, but I took a summer job at what was, well, isn't it? It was one of the medical schools in London, Royal Free, which is now part of UC. And the person I worked with said, you really should do a PhD. So I did do, but I did it, it was very applied. And by that time, I decided this was really what I loved. So I'd done some other jobs along the way. I'd spent a couple of summers working the stock exchange. I'd done all the usual kind of student jobs. But I decided finance wasn't really what I wanted to be doing. And I knew when I was I think it was good that I tried out these other things, because when I then worked in this research world, I was just completely absorbed in it. I liked its values. I liked the work. I liked the way I was using my brain and drawing on my statistical training, but having new things all the time. But even then, I didn't think I'd be an academic. I just thought, well, I'll do some research, and then there must be other places that you can do research like that. And then, I eventually sort of went for a lectureship for reasons that are perhaps that were to do with a mixture of family and other reasons. And I've always liked teaching, so I got to do some of that. And things went from strength to strength. But at no stage did I actually think, oh, I want to be there in 5 years' time. But each time I did what I enjoyed, and then someone said, well, you could do this, or the next stage is that. And I think for a woman of my generation, there weren't many women doing this. There were quite a lot of working, but not in the more senior positions. So if I looked around, it was men I saw, and somehow, although I was never that intimidated by them, I didn't instantly think, oh, that's the path I could follow. So,
well, I'm glad you accidentally became an academic, it seems, and
yes.
not so bad. You've certainly had a wonderful opportunity to work with really fantastic people and do great things yourself. So that's
no, I'm very grateful. I stumbled across, I suspect I might have ended up one path or another, but I was lucky that relatively directly I was in with a really good team, and so I learned fast, and then opportunities opened up, so I was in the right place at the right time. But no, I've never regretted it. It's been it's a brilliant place to work.
Rachel, you too. You've come into your PhD studies with other experiences first, so you're doing what you love. Perhaps you can tell us about your journey.
Yeah, I think very much like Deborah, I also love maths, and I'd had some really encouraging teachers right from a primary school level, and I think they really helped foster that. So I think what was obvious to me, I pursued a degree in maths, but actually it was at the end of that I didn't really have any idea of what I wanted to do. I'd undertaken internships in like the finance sector, and I'd got a few other experiences, and that had helped me work out what I didn't want to do. But it didn't help me work out what I wanted to do. But then actually after graduating, I probably quite by chance ended up stemmed from a conversation actually with my old maths teacher, going along to do a sort of summer work experience at a clinical trials unit at Cardiff University. And that ended up turning into a 12-month role, which I only really left to go off and pursue my master's at that point in medical statistics. And I think the bright lights of London were shining from Wales. But even then, after that, I think at the end of that, there were lots of people going off to pursue PhDs at that point. And for me, I still wasn't sure that I wanted to do that. So I went off and got some work experience, and I moved overseas for a few years working at a academic clinical research organisation. And it probably took me, I think it's 7 or 8 years of different sort of settings and working on different types of projects that it was only then that I really had an idea of the sort of topic I might want to pursue as a PhD. So yes, didn't start that until 2018.
So these are really interesting trajectories. Perhaps the statisticians, you don't just roll dice at every point and make a decision. You're really drawn by what interests you. I want to perhaps think about some of the school students that may be listening to us. And Deborah, I know you do a lot of outreach work, and you both have really great messages for students who also, like you were at the time, not sure about where they want to go and what they want to do.
Yeah, I mean, I think I'd say first of all, don't stress too much about it, but obviously work hard, sit and take opportunities. So it's very easy to look at someone like me and thinking either I'll never get there, or oh, she must have decided to follow this path. And it, as you've heard, it didn't work like that. But I would say, study what you enjoy. I studied maths primarily because I really enjoyed it. And then I did some other things that went well with that. Because studying can lead you to places that you didn't think was possible. But I would also say, if you like maths at all or you're good at it, it is worth taking a bit further because it underpins so many other things. So people who go off to be engineering or accountants or all sorts of other professions, you actually need, or economists, you actually need a bit more maths than you think you're going to. So I would encourage people to keep that up, even if that's not your direction of travel. But don't be afraid to try new things. So I didn't think I was doing statistics, but then I got inspired at university and I did. I've worked in different places. You've heard both Rachel and I say we've tried things out. Some of that was school holiday jobs, some of that was other jobs. And in doing that, you work out what, and you're not going to be the same as anybody else. But so, I mean, there's a few things, if you want to be a medic or you want to be a vet, you do need to do that particular subject at university, but there's far more flexibility than anybody would think possible. So start with what you enjoy and then work hard at that and then see where it leads.
Those are great messages. Clearly, you both really enjoy what you're doing, and it's very gratifying. Rachel, you also had a non-linear path so far, and maybe you can, what's your advice to younger students?
I think it really reiterate what Deborah just said, and that it's okay not to know what you want to do. Like you said, the path's not linear. It's not the same as everyone else's. And just to say, if you do want to, if you do enjoy maths, it really does open up so many opportunities. So you can take your time, get to do different work experience and things that you think might interest you, try it out. There's no rush with these things. So I think, yeah, that would be very similar to what Deborah has to say.
I'd like to.
The other thing I would say is that you don't know what's coming. So if we think about medicine, when I was at school, we thought infectious diseases were kind of dealt with and solved, at least in the Western world. And it was while I was doing my PhD that we heard about the first few cases of HIV, and some of my immediate contemporaries got involved in that work and have gone on to work out what it was, that it was an infectious disease, how to treat it. And it's taken some 4 decades to bring it down to now a disease like diabetes and others that you just live with. It was the skills and the education that help you do that. And we've seen the same with COVID. We've talked about how the skills we've learned on other things, then with this new challenge that nobody understood, I mean, we know some about infectious diseases, suddenly all came together. So I think if you're thinking about the kind of jobs that you're to people at school age here, but if you're thinking about the kind of jobs your parents or your uncles or your school teachers are doing, that's not the world you're going into. So it's another reason to learn how to learn and to be flexible so that whatever it is you can step up, because it's really fun being sort of involved in something new.
Yeah, and Rachel's demonstrating that in the middle of her PhD to get involved in a COVID trial. That's a certain generation, and some years from now you'll be telling another audience about back in coronavirus days. Well, that's really inspiring, and I think I would like to really encourage our audience to send in questions, and don't be maths phobic. And you can ask anything you like about our colleagues or about the subject. And just going on with, I know that we have a lot of adults on as well, and not everyone's perhaps as appreciative of statistics, and it's hard to appreciate sometimes until you learn more about it or see it in action. Clearly, we read a lot about statistics now with pandemic and a lot of the data that's being shared. Do you have any suggestions for people, adults that might be mildly interested in statistics and how to learn more?
Yes, I mean, the first thing I would say is that a lot of people seem to be afraid of statistics. And if I look at tables of numbers or graphs and I don't really understand where they're coming from, I get confused too. But what helps is if you understand the area. So most people, even if they think they're afraid of numbers, actually are pretty good at the things they care about. And whether that's going to the sales and looking at the money off, or people who go and have a flutter on the horses, understand odds. So what I find with my clinical colleagues is that often it's a set of data on something they care about that starts to get them thinking, and you think about it and you chew it over, and then you discover that a statistical technique helps you understand it and shed more light on it. And that's how you start to get into it. So I think what I would say to anyone listening who wants to know a bit more is do it in territory that you care about. If you go and read some stats book with examples from something that you really not that interested in, it's going to seem dry and dull. And I certainly wouldn't start there. So there's some good things on the radio. Tim Harford has a very good podcast and radio program called More or Less, where he drills down into what are the issues, what's the statistics underpinning them, and talks it through. And we've got some very good material that Imperial have put together. So we do some online degrees, and some of those elements of them are available freely. You could watch those. If you're interested in COVID, we did a very good set, which was funded by the Jameel Foundation, to explain to people what COVID is. Now, it's not just about statistics. What that does is to bring together the science, because statistics is best seen in context. So watch those. I always regard it like learning a language. To start with, you'll just pick up a few things. And if you run away, you'll never learn any more. Whereas if you keep listening and then sometimes ask someone, what do I do, or how do I say that, or mimic it back, you start to get into it. And then you might want to go and look at some of the textbooks to do it systematically, a bit like you learn your grammar systematically. But you don't, if you start with the grammar, it can be dull. If you start with, how do I order a cup of coffee? How can I order a pasta? A little gets you quite a long way. And if you need the rest, you can work it out. But for many people, actually, just an understanding of what it's about and how to critique statistics, it can be abused. So you want to know, listen to what's gone wrong and how can it be done better. David Spiegelhalter is another great person to listen to. He's a really great communicator, statistician who I've been very inspired by over my whole career. And again, the way he talks, you will learn from that. And you may not even realize that you're learning statistics.
Yeah, I'd reiterate that and say that David Spiegelhalter's also got a podcast. I believe it's called Risky Talk.
It is, yes.
Yeah, which I'd also recommend people seek out and have a listen to that as well.
Mm.
Yeah, people have an interesting challenge with risk, and sometimes get much more concerned about something that statistically is much lower risk than something else, than something else which is a higher risk. So that's really interesting. And these courses, you mentioned our online courses, and we can send a link to that. Our Coursera courses and other materials are more and more is available so that people can become more informed.
Alice, I've lost your sound.
Sorry.
That's better.
Question from the audience. Akanksha Sahu asks, to what extent do statistics influence the prioritization of patient treatment and care? For example, in invasive surgical procedures, how do statistics influence medical ethics scenarios?
Gosh,
So
what a great question. Absolutely, they inform nearly every treatment that you're likely to have, and that's partly because there may have been trials to work out the benefits, and as Rachel has emphasised, to understand the risks, partly because they should be used to communicate with patients, so that when you go in, often what patients often know that they're taking, that some treatments have downsides, but they often want to be fully informed. It may influence the planning of hospitals, so in all sorts of ways. But Rachel, you've probably...
Yeah, just thinking about, in terms of thinking in the clinical trial world, we will speak to patients and the public from the very beginning, from the sort of design stage, to work out whether that's a research question of importance to the patient population, and then get their feedback on what's the most appropriate outcome. So what do they care about in terms of what we change, and then inputs on lots of different things about how we run the trial and the design and things like that. And then when the trial is ongoing, they will often sit on our advisory boards and take part in that sort of that multidisciplinary team setting. Yeah, they're really at every stage in clinical trials, we would be speaking to patients.
Yeah, and just to pick up on the second part of that question about ethics, if you haven't got for an individual patient, if your doctor is not well informed either personally or because of the protocols and guidelines they're following about the benefits and risks of treatments, then that isn't necessarily terrible ethical. In particular, if there are difficult decisions to be made, then explain to patients or maybe their relatives what the balances are, what are the risks you're taking if you have this operation are important. But in the kind of work I do, what I talked about earlier about whether we stop a particular treatment arm in a clinical trial yet is often balancing the ethics of the patients in the trial. I mean, if they're at risk, we would stop it. The more delicate balance is, if the treatment looks to be going well, have we got enough evidence to change clinical practice? So you're trading off not yet giving it to everyone, but if you stop it too early, then no one believes you and no one gets it. So all the while we're interacting, and some of these things are very straightforward and others are really quite delicate. So we're discussing ethical things all the time. Statistics is not the only consideration, but absolutely it's a key element to getting that right.
Absolutely, very good, thank you. We have a related question from one of our colleagues, Professor Sonia Saxena, Director of Imperial Child Health Unit in the School of Public Health. I'll read it, it's a little bit long. How can statisticians and trial teams be mandated to include relevant representative populations? She goes on to say, for example, medicines and products for women, including a small minority of pregnant and breastfeeding ones, children, and many often disenfranchised minority groups who are typically underrepresented and also disadvantaged in having poorer health. Whose responsibility in it, and what are your thoughts on strong measures only, please?
Right, brilliant, Sonia, thank you for that. So the issue here is that when we do research studies, very often the kind of people that go into them willingly and volunteer are the relatively affluent, relatively healthy, or people with good risk. And yet the people who most need those treatments or medicines are often rather different. And it's trying to make sure that we understand how those treatments are going to work in the wider population. So there's a big debate about who should be in trials. And there are challenges. So drugs are very often not used initially in pregnant women because of going back to the thalidomide disaster, but you have to think very carefully about when they should be tested. I think the answer, I would just take a slight umbrage at the word mandate, because I think you can't force people to take part in trials. But what you can do is use levers. So I've spent another thing that I never thought I would do was be involved in drug regulation. And that's looking at all the data that pharmaceutical companies put in to see if they can have a license for a trial. Those regulators have a lot of power. So the example I'm going to use is children, because a lot of drugs are tested on adults, but they're then not properly evaluated in children. It's not a big market. They can be difficult to study in children. And so, to be honest, a lot of children's doctors, pediatricians, are making judgments based on quite poor evidence. what the regulators did was grapple with this, and they put in some incentives, sort of patent incentives, if you did trials. And later on, what they did was to say, you can only have a license in adults if you come up with a commitment to the studies you are then going to do in children. And I think that's the right way around. You study in adults, then in children. So that's a group about whom we need more evidence that there were some good levers. How we do that in other groups, I think, is still working through. You clearly want to see often the people who are studied are men, so you want more women. But I think once you start talking about different ethnic groups on, you get into quite interesting questions about what is a genetic group. And you have to think through quite cleverly and carefully what it is you need to know, and have you got the right people in the studies to answer those questions. But I absolutely agree, it's partly an ethical thing, it's partly clinical, but there's actually quite a lot of statistics in that, because if we study anything, we study variation and diversity. And you've got to think about the data to plan properly for what you need to do, and then to disentangle it afterwards. So, it's not an easy question, but then that's the kind of question I enjoy doing.
Well, Rachel, as you prepare for your PhD dissertation defense, perhaps you can think about that as well. And I'm sure when you're dealing with COVID, you're dealing with a certain cadre of patients in the clinical trial.
Yeah, and it's also true that for adverse effects, Rachel, I'd be interested in your views, because some of those patients may be the ones who are more likely to get bad effects of treatment. So it probably matters even more from that perspective.
Yeah, and I think this is where a lot of the arguments come in about the sort of post-marketing setting, about the advantages they have over looking at these harms in clinical trials. But I would argue that the data that we get in the RCTs, that control arm, so we have a comparison and not receiving the intervention that adds so much more value. So I think we shouldn't be wasting that opportunity in the RCT setting.
So we have an anonymous question on how central a role do you think statistics have played during the pandemic? During this time, have statistics played a big part in public health decisions in a way that haven't quite been done before? They haven't quite been done before.
I mean, I may be biased. I am a statistician after all, but I think statistics, I mean, I've always thought they're important, but to my mind, they've really come into their own. So from the early modelling that Neil Ferguson did, that actually said, based on the limited cases we've seen outside of China, that must mean that this is a very contagious disease and that there must be rather more of it than we know about. So that was both statistics and modelling. Through the, at Imperial, we're doing the REACT studies, which every month sort of look and see what's going on with the statistics. It's data and statistics. I've talked about the trial I'm involved in. There are other ones. It could not be more centre stage. And you can talk about the decisions that have been made, but my understanding is that at every stage, statistics and data has been in there. I mean, Chris Whitty talks about, all the time, what does the evidence show? What do we know? What do we not know? That has to be weighed against all sorts of political judgments. And I'm not a politician. I'm quite glad at the moment. But I think it's been absolutely central. I think a lot of people have now got a much better understanding than they had before. But it has been quite overwhelming, the pace at which data is coming through and discussions. I'm struggling to keep up. And this is the kind of stuff I live and breathe. But what it looks like from your perspective, Rachel.
Yeah, and just carrying on from that, the pace of things as well. What's been interesting from the COVID trial is the actual sort of external demands for us maybe to have results before they're ready, and maybe share things before they're ready, just because it's been so fast moving and people want to know what drugs are going to work and what drugs aren't. And it's balancing that about at what point we can release this information and actually doing it too early when it just causes more confusion and adds noise to an already quite noisy arena. So yeah, it played a big part, but there have been certain pressures.
Yes, absolutely.
And it's been very impressive. And as you pointed out, Deborah, that first study by Neil, based on 3 cases outside of China, showing that probably it was human-to-human transmission, was an international wake-up call, and is something you could analyze from your mathematical point of view and come up with a similar idea. Okay, we have a question from Beatrice Gualo. How can we as statisticians, make sure there's an appropriate involvement of patients in trial design to decide key numerical aspects, for example, target differences?
Okay, thank you for that, Beatrice. So for those who won't know, what a target difference is how big a difference do we need between treatments before we're actually going to use it? And that is one of the key things that decides the design of the trial, how big a trial is going to be. So I think the answer is the patient representatives, sometimes that's charities, sometimes that's there's other ways of doing it. We've got the Patient Experience Research Centre at Imperial. Those patients need to be designed to involve really from quite an early stage, as Rachel said, what's the prioritization of which questions we're looking at? And then out of that will come, and it's really a question about trade-offs. What at individual level would I trade off, perhaps in terms of side effects of a particular benefit? If you're talking about chemotherapy, you're often trading off losing your hair, feeling nauseous in order to have a better chance of surviving another few months, or in some cases, actually surviving another few years. And there's work one can do, and I think of it as a conversation. If I turned up to a patient and said, so what do you think my delta should be? They go, Whereas if you start saying, well, what do you think is worth it? Then you can have that. But the key to that is having a relationship with those groups first, so that that kind of question doesn't come out of the blue. And that's where the kind of clinical trials units, such as the one Rachel works in, that's one I helped set up, work with patients, Patient Experience Research Centre, which is part of our Biomedical Research Centre. They set the framework so that, and it's partly about us as researchers learning to work much better with patients and the public, and partly that patients and public learn to work with researchers, and some of them really keep us on our toes.
Yeah, I think I'd just add as well, it's about how we then communicate with it, because I know this is already quite a tricky task when we have to do it with the clinicians. You know, you can have lots of back and forth for quite a long time trying to get that target difference from the clinicians who are designing this study, and we have to be really careful and think about how we communicate that with them. So it's a great question. It's not, I don't have an answer. It's not an easy thing to do, but yeah, very important.
We have another question. What sorts of challenges, if any, have you come across when using statistics to improve patient treatments? And they thank you for sharing your stories.
Gosh, I mean, I could tell you all sorts of stories of difficult clinicians who you say, well, the way we should design it is this, and they say, but we've always done it like that. But actually, I think what I'd like to highlight is a bigger question that, as in so many things, we're going to have some really good things that come out of COVID. And with the clinical trials, these what are called platform trials, where you do several treatments at once, something comes into care, and then you may already be randomizing to others. To me, it's the future, because the normal stop-start, we do a study and then it stops, and then you work out what the next study is, but you spend 18 months, 2 years, maybe 3 years getting the funding, and you've lost momentum. And I think this sort of structured way of thinking about trials, so that almost everybody who goes in is offered a randomization, because there's lots that we know and there's always something we don't know. That ties into how do we treat trials more efficiently, which is use of routinely collected data or real world evidence. That's not a panacea, but starting to think about this almost as improvement of treatment as business as usual, rather than a few people doing a set of studies that don't actually add up to much. And I think actually a lot of the other smaller irritations would then also fall into place, but it's not easy, and there's massive questions about who would fund it, how we fund it, how we keep the infrastructure going. But we've done it for COVID, and we've learned for REMAP CAP, which my colleague Anthony Gordon leads, we've found really important treatments. And we've seen in the statistics that the survival rates have improved even over the course of a pandemic that's barely lasted 18 months yet. So that shows what you can do when you've got organisation and that's another one, good Bayesian statistics.
There's been good connection across the UK, isn't there? The ISCARX C4 or whatever, Europe as sharing of data around the UK. I've been very impressed with some of the clinical outcomes, and as you say, how they've been improving in the over the year and a half.
Yeah.
Rachel, you collect all kinds of data, and you're very interested in this question of pulling it all together.
Yeah, it's been really wonderful with the COVID studies to see what we can do. I think Deborah raises a really great point about thinking about how we fund these things going forward. It's like you say, quite often you will do one study and it then stops, and you're reliant on securing funding again to carry on, and that's not always a given, and especially when it comes with the side effects or harms, it's not going to be established from one study, so we are reliant on these lots of studies. So hopefully we learn something from COVID, and there are changes for the better for the clinical trials community.
Absolutely. Someone's asking, what are the benefits of doing an intercalated degree in statistics alongside medicine? Would you do both? People there, at least someone out there wants to be like you. So,
okay. So for those who don't know what an intercalated degree is, medicine is often a 5-year degree, but many universities have a year that you take sort of after about second or third year that give you a specialisation, which give you an honours degree, and that's called intercalated. If it's not different medical schools offer different options. So I think if your medical school that you go to offers that, then that could be a very good thing to do. Others may offer it in epidemiology or something similar. But I think the more general point is there's certainly benefits if you're doing medicine of studying statistics, whether it needs to be an intercalated degree or whether you learn it. Most medical curriculum have some statistics in it. So do some of the trainings you then do. But I would strongly encourage it. I think whether the statistics is what you need to do, or whether if you want to work in cardiovascular stuff, you do cardiovascular, that's a personal judgment. But if you've always been interested in statistics and you've got the option, then I know some people who've done that in the past who've gone on to really great careers. So yeah, it's certainly worth thinking about.
Yeah, and anecdotally, I've over the years of being involved in some teaching, I always had people come in and saying, they didn't realise when they were doing their medicine degree quite how important the statistics aspects that they had done would become, and they wish that they'd paid more attention then, because they're now now they're a doctor, come back and learn these things. So if you enjoy it, then I can't discourage it.
No. But I think one of the things I think that's been coming through is you need to understand both the subject matter and the statistics. So yeah, doing an intercalated degree would actually be a good way of getting both, but don't worry too much which order you do them in. I know some statisticians have then retrained in medicine and gone to great careers there, and I know plenty of people who started off doing medical degrees and doctors and have then either picked up some statistics along the way or have gone and done master's degrees in statistics or related things like epidemiology or public health. So yeah, I wouldn't get too hung up on the order you do these things, but absolutely learn as much as you can.
I had a PhD student who, when I was at Stanford, used to go up to Las Vegas, and he wasn't studying statistics, but I'm sure he thought his mathematical skills helped him. I don't know if you have comments on how we experience statistics in everyday life, and what people might do to start thinking about statistical mathematics in some simple examples.
Gosh, well, the kind of games we play, you play with dice. That's got 6 sides, and if you've done any statistics at school, it often starts off when you start with tossing coins that only got 2 sides, then dice. Now, I don't know whether I should be saying this, but one of the things I enjoyed when I was at school, I played cards, I played a bit of bridge, but I somehow got in with a group who played poker, and my goodness, just thinking through which cards are more likely to come up, which aren't, where they might be sitting. It's true for bridge as well. It gives you an advantage. And when I was a sort of a fairly sort of a teenager with long blonde hair in the 70s, that some of the men were they couldn't work out why I was winning. So I think the answer is that if you use statistics, you can use it waiting for the bus, what's more likely to turn up. But it goes back to my point that if you use it on the things that you are doing and care about, it starts to fall into place. And actually that had an advantage, because when I then went to university and we got these stats questions, by then we'd moved on to packs of playing cards, and the questions were, are you more likely to get a flush or a royal flush? I could see some of my better brought up colleagues had no idea what a flush or a royal flush was, and I was in my element. So it gave me a confidence. And I'm not suggesting go and play poker, and I only ever played for pennies or matchsticks, because gambling is a different kind of problem. But yeah, you can learn quite a bit from just playing and trying things out and then working it out sort of more formally.
Rachel, I don't know if you have any games you like to play, or things you...
Nothing quite as exciting as poker, but I think there's a missed opportunity there for me that I'm just learning about. But yeah, always very much brought up on the playing cards and games that there's a game Rummy Cub, thinking about numbers. And so yeah, for the younger audience there, I can highly recommend something like Rummy Cub.
Yes, good. And I really have to get into the idea of what we read in the news, and many of our experience of statistics. I hate to bring it up, but there is a definition of lies. There are lies, damn lies, and statistics. And so I just wonder if you're concerned about things you see in the media, political leaders using statistics, anybody misusing statistics. And maybe, in this year of COVID coverage, are there examples where it's been used well and places it's been misused, or you're distressed? But, how good should we feel about statistics we see in the popular press?
I think what I'd like to see is people developing the confidence to query and ask things, because statistics, as we've seen, have been enormously helpful, for example, in COVID, but in so many other areas of life. But they can be misused, and they can be misused perhaps in academic life, where people just put up something that's a bit too clever to try and bamboozle. But they can be used to mislead. I don't particularly want to blame politicians, but that's often and often it's something used out of context. So organisations actually the Office of Stats Regulation has a monitoring function of how government statistics are used, how they're produced, but also how they're used and talked about. Wonderful organisation called Full Fact does a lot of fact checking. Robert Cuff on BBC, again, will call things out. But I think just as you barely function in society if you couldn't read, you couldn't get on the tube, actually statistical literacy is good, because and I think a good rule of thumb is, if you feel that a statistical presentation has shed light on something and you think, now I get it, it's doing it right. If you come out thinking, I don't get that and I don't trust it, and you can't put your finger on what the problem is, there probably is a problem and you need to think about it more, but it takes some confidence to do that. But I think the standard of statistics, on the whole, that the good outweigh the bad, but it can be absolutely sort of misused either deliberately or very often inadvertently.
Yeah, I just add as a consumer of those things as well. I think I just don't rely on one source. Read around if you can, and also read things with a critical eye. That if it sounds too good to be true, it probably is too good to be true. And I think to add to the resources that Deborah was just mentioning, the Science Media Centre is a great initiative that works with journalists about science and media, and it can help people draft their press releases, but it also gets experts involved to look at press releases and look at studies and actually critique them. So I think if you are really interested in something, you can go away and check it out on the Science Media Centre.
I was wondering how much of the media, employ a statistician on staff to help them with their fact checking, or rely on experts, or would call you up. Deborah, you must have gotten plenty of calls during this past.
Absolutely. Some of them will, BBC employ Robert Cuff, who used to be a statistician in the pharmaceutical industry. Many don't, but they develop good relationships. And I'm on the Circulationist Science Media Centre. So every day we're getting stuff around. Would anyone like to comment on this? Or can a journalist talk about this? And sometimes we take those calls. Sometimes it results in going on television, but very often it's about, it's someone saying, look, I'm trying to present this. Can I test out my ideas on you? And the Science Media Centre have done a fabulous job. The Royal Statistical Society has done, again, a lot of good relationship building with journalists. One of the things I did some years ago was teach on courses to help journalists understand statistics, to help them interrogate it, because often they're moving so fast, they can't always go to a statistician, but they can learn how to do it. So, but I think organisations develop much better relationships. And I think, again, I think it's one of the reasons that we're so much more aware during COVID, because they had that to draw on. What's happened in COVID hasn't come out of thin air. It's come out of a good base. And I know Rachel does some stuff with the that also helps sort of promulgate good statistics. But yeah, in the media, they are desperate. Journalists are trying to get it right. Often the headline writers are a bit kind of, but actually, if you read the article, 9 times out of 10, that journalist is trying to give an honest description of a complex picture with a tight deadline. So anything we can do to help, they're generally very grateful for.
Indeed, headlines are dangerous, and I think also we've during the pandemic come to get used to a bit more of the presentation of data, graphical presentation, analysis in different ways, thinking about our numbers, thinking about rates per 10,000 population, et cetera, because raw numbers can be quite misleading, as well as averages. And, it's perhaps there is a teachable moment here. And as we have some online resources for people, we should think about post-pandemic, how to take what we've learned and help people be good consumers of statistics and of information.
No, I couldn't agree more.
So
there's some great stuff on the Imperial website. So
we'll send out links to the people on this call to consider resources that they might use. Rachel?
Yeah, and I'm just trying to think. We also have a stats website within the ICTU clinical trials unit team on our methodology, and there's some blog posts there that might be of interest. I'm thinking of one in particular from colleague Susie Crowe, who spoke to the public about how we can communicate on the vaccine effectiveness. And I think and it uses some visual approaches, and so it's a really nice resource, I think, and uncertainty as well, as you said.
Yes, absolutely.
That's great. And the efforts to make vaccines real through some of the celebrities, seeing Elton John get his jab was very influential and impressive. And we need to make sure we have influencers helping us with facts. So, well, it's been marvelous talking to you. And thank you, Deborah and Rachel, for giving us these insights. And I want to thank our audience for joining us. The next Imperial Women Luminaries event is called When Infections Go Viral. It'll be on Tuesday, June 22nd with Professor Wendy Barkley and Dr. Vanessa Sancho Shimizu, two very inspirational women in infectious disease and virology. So we look forward to seeing you then, and thank you very much. It's been a wonderful afternoon. Thanks.